Yadav, KIMS Hospital, Secunderabad. Today, I have been assigned a very important part of the nerve conduction studies, that is the EMG. And I hope all of you have been introduced to EMG and you have been doing EMG in your day-to-day practice. And I do agree, this is I am trying to cater only to the exam point of view, but in future, also in our clinical practice, we should not forget to use the needle to diagnose the problems. And now the basic point about this will be only three things: why, when, and what. This is the most important thing about EMG or whatever be the clinical problem. Why is this occurring? When are we going to do the EMG? And what are our findings? These are the three questions we need to ask whenever we are doing a EMG. Now, before that, I hope all of the residents can participate in our discussion, because I would like to have it a two-way discussion. Now, once you are given a nerve conduction studies, what is the thing you will look at first to decide where is the possible lesion? Anybody can answer it, then we'll go forward. You've had a clinical patient, you did a nerve conduction, you are given a report. What facet of the nerve conduction you will see first? That's a simple question, and then we will see how to go ahead. Anybody can answer.
Dr. Asta, you can try.
Yeah, please go ahead, Dr. Asta.
Yes, sir. So we'll in the nerve conduction study, we'll see there are aspects of it, like whether it's a mononeuropathy, involvement of one nerve or more. We'll try to localize the lesion, like whether it's axonal or demyelinating, the severity of that, and the temporal course we'll try to understand further.
To decide whether it's a mononeuropathy or a mononeuritis multiplex, you have to look at motor conduction, nerve conduction, H reflex, F reflexes. Among all of those parameters, what would you like to see first?
Sir, amplitude of the nerves.
Yeah. Now I will take forward. Now you see, when we do a nerve conduction, we are checking the motor component and the sensory component, right? This is the trick. What would I would like to say? All of us, when you have a nerve conduction in the hand, look at the sensories, right? First, you have to look at the snaps. If the snaps are down, now you are sure that you are dealing with a sensory neuropathy or a sensory motor neuropathy, right? The problem arises when the snaps are normal and you are dealing a patient with a lower motor neuron disorder. When the snap is normal, then you are not sure where is the lesion. Is the lesion at the muscle, neuromuscular junction, combined motor sensory nerve, or normal motor nerve, or a radical, or an anterior horn cell? Is this clear to everybody?
Yes, sir.
Yes. Therefore, when a nerve conduction is given, rather than looking at the first page is always the motor conduction, but just flip the paper and look at the snaps. Snaps are normal, then the problem arises. What are we dealing it? Is it a radical? Is it a motor nerve, combined nerve, NMJ, or muscle? Therefore, in a hypothetical patient of LMN syndrome with snaps being normal, then you do a motor nerve conduction, various parts are involved, then you decide I have to go ahead and do the EMG. Okay, clear everybody?
Yes,
always keep in mind, when our nerve conduction is given in the exam, flip it, look at the snaps. Snaps are reduced, your life is easy, because this is a simple neuropathy. Snaps are normal, then the problem arises. Okay. Now, before going to this, why I told about this. This is a patient I faced yesterday only. The orthopedician had referred to me. This is a 12-year-old young guy who came with walking difficulty. He was waddling. And as soon as I saw him through the door, I thought, okay, this is a, possible muscular dystrophy, possible Becker's. This is what I made up. And as I removed his shirt, I was much more convinced because there was differential wasting, which involvement of the posterior fibers of deltoid was gone, and he had a mild lordotic gait. And but one thing was that there was no calf hypertrophy. Next, sensories were normal, but problem came that when I tested his reflexes were absent. Then I had a doubt what I am dealing with. And further, the parent also told that no, this problem has not been progressing. Therefore, in such a hypothetical patient, we think of whether this is a myopathy versus a neuropathy, right? In the myopathies, we think of a muscular dystrophy or a congenital myopathy or neuromuscular. We should remember congenital myasthenias don't present normally as a fatigability. They can present simple with a progressive weakness. And definitely neuropathy, at what level the problem is, this was the problem statement I had. I sent for CPK and I did a EMG. This I will come to it last. Now, what is electromyography? As simple as that. It is the record of the electrical signals which come for the muscles. Now, what does it do? By looking at the recording, we try to localize the disorder, and we also try to characterize the disorder which is occurring in the motor unit within the muscles. Before going further, I'll just recap. We will go ahead and see what is a motor unit. A motor unit combines of whole of a motor nerve and all the muscle fibers it innervates. For example, in this simple diagram, if I look at the anterior horn cell and the radical, then this small twigs, what we are seeing motor unit 1, which is innervating some muscle fibers, and we are also seeing motor unit 2, which is innervating some muscle fibers, and all of it combines to form a muscle. Therefore, when I'm talking about one motor unit, I mean to say that the problem can be in this muscle, in this motor twig, axon terminal, or in the radical, or in the anterior horn cell. This is the whole of it which I am trying to find out by doing a electromyography. Now, when do you think what is a reliable EMG? EMG as such is it takes time, and over a period of time we develop our own methods to have a good EMG recording. The function of an EMG is that after we assess that there is a neuromuscular problem and not a simple sensory neuropathy, we go for EMG. EMG involves definitely inserting, moving, and recording with a needle electrode. This all requires a lot of practice. Over a period of time, we pick it up. That is the feel which is passing through a muscle, or the feel that is passing through not a muscle but a tissue, is very important. This we can find out only after putting a needle in multiple muscles. And last but not the least, EMG is all about visual pattern recognition and definitely auditory. Unfortunately, today the auditory part seems to be a little not good. I don't know. I have been trying, but what I'll do is that after our presentation, I'll share all the videos in the WhatsApp, and at leisure you can go through all of them. Now, there is a thought that why the needle EMG is so painful. Why shouldn't we just do a surface EMG? Surface EMG is that just the cup-like electrodes that we do for EEG. The same thing can be done for EMG. But the problem is that small things, the most important of it, fibrillation cannot be recorded, and individual MUPs cannot be recorded thoroughly. But in some patient, in a child, when we are at our wits and not able to find out, is not tolerating the EMG at all, definitely a surface EMG can be tried in such a case. Now, before going to discuss about the needle electrodes, I have to share few things. First and foremost, we have to, when we see a patient of with a suspected motor neuron disease or a myopathy, we have to decide what muscle to test first, right? Because if we make out that this is a myopathy, definitely I would like to look at the proximal muscles and then try to go for the test. For example, but if I think it is a anterior cell disease, then definitely I will make up my mind to examine proximal and distal muscles. Therefore, first, the clinical problem is most important. Second, another important thing is that this can be very painful. And for some reason, I don't know, some muscles are most very painful. After that, that we know that this is the last muscle which should be tested. And the last muscle which is normally is the APB. That is, and the ADM. And because they are very painful, normally we try to test them at the last. In fact, funny thing is that FDI when tested is not so painful, but APB is very painful, and we should keep it in our mind that we'll test the APB the last, because after that we know the patient won't allow. Therefore, as much as it's a skill, it is a tact. Therefore, if you are realizing that the patient will not cooperate, try to make up mind which muscle would you like to definitely see, right? If it is, for example, if it is a motor neuron disease and you are having only one muscle which you want to put, I would go for a FDI. FDI. If it is a myopathy, I'll choose a proximal muscle. Ideally, what they say, when you do a EMG, in each muscle, you have to check at 4 points. But in real life, it's not possible. In one muscle, once it's enough. But make it a point to check as many muscles as possible. Now, going forward, what will be asked? What are the types of electrodes you know? They can, this is the simple diagram which I had taken from the neurology clinics. There are three main needles. The commonest what we do use in our day-to-day practice is the concentric needle EMG. There are three types of it commonly used: the green one, the yellow one, and the blue one. And this doesn't connote what is the gauge of the needle, but normally the yellow one is the smallest and the blue one is the longest one. And the thing about the concentric needle as it is in this diagram, there is a shaft and there is a beveled end, and within this there is a thin fiber which is the active fiber, and this is the electric road. As shown in this figure, this is the active and this is the reference, right? With this, what happens? The sampling error comes down, and you will sample only the muscle which is exposed here, and there won't be any interference from the surrounding muscles. Whereas next, the monopolar one, here the whole of it acts as an active electrode, and you have to put the reference elsewhere. Therefore, the chance of interference from the surrounding muscles is high. And in clinical day-to-day practice, all of us use the concentric EMG. And the most important one, normally we don't have it, but some of the examiners may bring it. This is the single fire EMG, much thinner, and you will have a eye, as we see in a normal needle which we use for sewing. There will be eye on the side, and there will be a small electric wire in that. That is the trick. In the concentric, it is at the end, and in the single fiber, it is at the side. I tried to show it in our, but the active electrode, but the resolution was not enough. Now, next, when we do a needle EMG, what we all record, there are three things, as you all know. Once you look at the insertional activity. In the insertional activity, you look for spontaneous activity, right? Then you look at the activity arrest, and then you look at the muscle contraction. Now, this is a wonderful image which you would have seen as shared by Dr. Ramakrishna umpteen times. What does the spontaneous EMG activity mean? And where does the problem arise from? This is an image, by the way, taken from Shapiro. All of you would be knowing. And first thing first, when you put just near the end plate, you can get a end plate spike or a noise. Or when there is a pathology, in the muscle fiber, you will get a fib or a positive sharp wave and a myotonia. And when there are multiple muscle fibers involved, you get the CRD. Whereas if there is distal or if it is just proximal involvement of the axon or the motor neuron, you can get a fasciculation myokymia. I'll show what is important for our exam. Now, most important is that what is a fib, right? It is activity from the single muscle fiber, right? What happens is that when the innervation of a muscle fiber is lost, it becomes active, hyperactive, and it starts firing. The features about is that most important feature about fib is it is a regular firing with a range of 0.5 to 15 hertz. And the sound, as you all heard, it is like a rain on a roof, not a simple roof, but a tin roof, right? Fibs can be either in the form of a spike or a positive sharp wave. And other important thing is that also we should remember about the end plate spike. I'll show one by one, right? This is the end plate spike. This image is not our recording. This I got through the YouTube, and I'll share later so that you can appreciate the sound. Oh, sorry. This is the normal recording, right? If you have not heard the sound, don't worry, I'll share it. But what you have to appreciate is that as soon as you put the needle and wait for some time, if you get such a recording, there is this feature which suggests of a MUP, but there is only a negative wave. As you all know, be knowing, negative wave in a EMG is the positive deflection up, and there is a positive wave downwards, and that there is a sputtering sound to it. It suggests that it is a end plate spike. The feature about this is that it is not regular, it is irregular, and it looks like a MUP, but the feature is that it doesn't have a initial downward deflection. It starts with an upward deflection and later it has a downward deflection. Appreciate it in full. Is it okay? I'll repeat it once more. Hope everybody could appreciate it. Now, the next important, the most important what we look at is a fib and a sharp wave. Definitely, I'll share it with you. But what you have to appreciate is that this is a video just of the fibrillation. And this is the video of a positive sharp wave, right? In a positive sharp wave, we have an initial downward deflection. No other deflection is that. And the feature about it is also regular. And contrast it with a fibrillation. The other feature, what I would like to say is that as you put the needle, you have a burst of activity that is called as insertional activity. Therefore, after you put the needle, as there is a destruction of the nearby muscle, you will have a burst of activity that doesn't mean anything. But after waiting for 1 to 2 seconds, you should analyze it. I'll play it for you once more. This is the initial insertional activity, and normally after few seconds this dies off and you can record the fibs, right? The small activity what you see which consists of multiple waves that constitutes a fibrillation. The feature about this is that if you can appreciate the sound, it's well and good, or you can hear it at a leisure. There will be a typical sound regular of a raindrop on a roof. Now, the other thing what I want to show here is also a muscle fiber discharges, which is the myotonia. The most important why it is a favorite of all the examiners, because they would like you to talk about a dive bomber, which you don't see, which we can see only in the theaters, but it's like a motorcycle revving. Some of them who in a standing motorcycle, if they accelerate, the sound which you can hear, that is the myotonia. Here, what you should appreciate is that what you should notice is that this type of activity, it waxes and wanes. In fact, it is called as a sinusoidal activity. Here we couldn't find the full sinusoidal, but there was a typical sound. It can be spontaneous, and once it comes down, you can see that there is some activity going on. But once you move the muscle or move the needle, again it comes back. Therefore, the last part, if there is a voluntary contraction or a needle movement, you will again hear it. This is a typical feature of myotonia. But we have to realize that whenever you hear this sound, it doesn't mean that it is always a myotonia congenita or myotonia dystrophica. Even in it is a non-specific feature, you can see in many chronic neuropathies or axonopathy. Now, when we talk about the fasciculations, now the distal part is that part where you have fibs, a positive sharp wave, or a myotonia. When we come proximally, when there is involvement of the motor or axon or the cell body, you will have a spontaneous randomly discharged MUPs that can be generated from any part, from the anterior horn cell to the axon. Feature about is that it fires irregularly, and you can see that it is like a pop, like a popcorn kernels which have started to pop. And other feature is that it is irregular. And fibs, you cannot appreciate them, but when you see a fascic, you can definitely see on the skin there is a undulation on that skin, suggesting a contraction going on. This is a classical fascic. Yes, in this only you could see that there are 2 to 3 types of fascics. Why? Because it can suggest that there are various type of degeneration going on, either of the axon or of the anterior horn cell, which is well seen in this video. Irregular firing along with different types of fascics. These are classical of a fasciculation, and you have to make sure that the patient is not contracting his muscle, and you can see them on the skin of a muscle contraction. Now, after the first part, what we next look at is a voluntary MUP. One thing about the spontaneous activity is that how much you should wait. Some say 30 seconds, but where I was trained at NIMS, Rupam sir used to say you should wait long, 3 to 5 minutes, if you clinically think that there is a myopathy or a axonopathy and you are looking for a fib or a fascic, you should wait for minimum 30 seconds up till 3 minutes. Now, next is the MUP. What does a MUP mean? When there is a voluntary contraction, we'll have a electrical impulse, and that it comes as a MUP. Now, MUP will have multiple phases, right? And it can have a down phase, a up phase, which will have turns. Again, it will come down and again will come to the baseline. Therefore, these are multiple features which you can see a MUP. What are all there? First is the duration. Duration means when it has started to the end of the till it comes to the baseline, right? And it ranges from 5 to 15 millisecond, and short duration usually occurs when there is a loss of muscle fiber. Long duration suggests the possibility of a chronic neuropathy or a myositis. Next is the amplitude. Amplitude is measured from peak to peak, lowest peak to the highest peak. That depends on the density and the type of the muscle fiber. Normally, it ranges from 100 microvolt to 2 millivolt. Definitely, as there is a muscle destruction in a myopathy, the amplitude will be decreased. Whereas in a chronic neuropathy, though the number of MUPs have come down, they are large in number because of reinnervation. We'll see some examples for that. The other important thing is that what do we mean by a phase? Number of crossings of the amplitude of the electrical activity is called as a phase, crossing the baseline. For example, you see here there is one crossing, again there is a second crossing, and there is a third crossing. There are 3 times the activity has crossed the baseline. These are called as phases. In a normal muscle, we can have about 2 to 4 phases. More than 4 phases is called as a polyphasia. The other important thing is that there may be change in the potential, change in the direction of the potential, but it may not reach the baseline. These are called as serrations or turns. These also have the same meaning, but as it is not reaching the baseline, they are called as turns. Other important thing is that many times when we have this activity, but the by side of it will have a small activity. That is called as a satellite potential. That is suggestive of a denervated fiber which has been reinnervated by a collateral sprouts. I'll show the MUPs now. I would like you to all appreciate the how much is the voltage. Voltage we have tried to record is of 1 millivolt. Here each division, if we calculate here 1, 2, 3, 4, 5, 6, 7, 8. This is a giant action potential what we are seeing. And on the side of it, I'll show you the satellite potentials. Appreciate the giant potential. Right? The potentials which we see side by the giant potential is called as a satellite potential. One important thing is about EMG is that you should get tuned to the sound we are seeing, and until you have a crisp sound, keep on rotating, not much rotating, but shifting the needle up and down till you have the good sound. Once you are having that crisp sound, then only it means that you are properly in the muscle and you should do the recording. Now, the other end of it, what type of you see in a myositis or a myopathy, you will see. Oh, sorry. Now, you see these are the recording now is 500 millivolt. Even in that, you are seeing such a small recording. This is the classic of myopathy. In this, where there are small recordings, and when you look at the duration, this is the start of it and this is the end of it. The whole of it corresponds to a one motor unit activity, what you are seeing, which is commonly seen in a myopathy. Last but not the least, what is the third thing what we look at? We look at the interference pattern. What do you mean by interference pattern? This is the activity which we see on the screen when there is a maximum contraction. Therefore, this you can quantitatively measure, but the most important thing is that visual impression. Now, this is what we are supposed to see in a normal tracing. As in neuropathic, as we know, there is a lot of motor units fall off. Therefore, you will see individual spikes. Many times this is called as a picket fence. And in the myopathy, you will see a early recruitment. Now, this is an example of a normal recruitment. Have a look at it. Again, have a look at it. Here we are asking the patient to maximally contract and see what happens. Now, this is a neuropathy where you will see even on maximum contraction, the recruitment is not occurring and you can record only few of the action potentials. And this is one example of early recruitment suggestive of a myopathy. As soon as the patient contracts, the whole of the epoch is covered with action potentials, suggesting that all of the muscles, they are acting at the same time, suggesting a early recruitment, which is classically seen in a myopathy. Okay. In the interference, have a look again. This is a normal. You'll have some time in the decreased. Very commonly, you will see that in spite of maximal contraction, the screen doesn't fill up. Whereas in a myopathy, the screen will fill up early, and whenever the patient attempts to do it, again it will fill up. Right? Now, these are the few important recordings which I have seen, which our examiners have been asking. They can ask about the electrode. Even in the spotter, they can keep a needle and ask you what is this type of needle. You can look at it, whether it's a concentric or a single fiber EMG. Then during the viva, they can have a trace of the recording, or they can show it on the video. In the trace, you will definitely obviously can't hear the audio. Therefore, the waveforms become very important. Whereas if there is audio, we will try to find out what is it. Therefore, normally they will ask for a fib or fascic or a neurogenic activity or a myogenic activity. These are the normal things they will ask during the exam. Other things what they'll ask is that when would you like to do the EMG? For an MND, normally once they come, they are already they're fairly advanced in the disease, and on the day when I see, I can do it. But we'll commonly get a case of a brachial plexus injury, road traffic accident. After that, the child or the person comes with a flail hand. When should you do? You should remember that even in an acute radiculopathy or a brachial plexus injury, the EMG changes take some time. The minimum time it takes is 2 weeks. Maximum it will take 6 weeks. Till 6 weeks also, you may not find any changes in the EMG. Therefore, in between, you should say that after doing the nerve conduction, if you find that there is some drop in the action potentials, make it a point that plan for EMG after 3 weeks. Normally, at the outset, I don't do, because the patient is already in pain. You won't get any findings. Therefore, always mentioned in the summary, I would like to do a EMG after 3 weeks. Even after 3 weeks, you are not getting anything. Just don't say that there is no damage. Ask them to repeat after 3 more weeks. 6 weeks is the time. Definitely, if there is a damage, if there is a radiculopathy, if there is a brachial plexus injury involving the which is beyond the neuropraxia, you will get changes. Other important thing is that what are the filter settings? Most important, this is another question they may ask, and you should all remember the low frequency filter, or that is called as high pass. That means above which all the impulses are passed, that is about 20 to 30 hertz, and the high frequency filter or the low pass, that is below that all the impulses will be recorded, that is kept at about 10 to 20 kilohertz. For this is for the routine EMG. If we do for the single fiber EMG, definitely the high pass filter is kept much up at about 500 to 1000 hertz. Now what happens, what you have to remember is that if you increase the low frequency filter, what happens is that all the small amplitude, small low frequency wave will be cut, and the amplitude will come down. And you can see that all the MUPs are appearing very short. Then you should realize that, okay, has the filter settings changed? And look at that. This is the most important thing what you should remember when you're looking at the technical settings before doing a EMG. Other important things, always ask if the patient is on our antiplatelets. Don't forget to look at the platelets. What they suggest is that a platelet count of minimum 30,000 is needed, above which you can do a needle EMG. And nowadays, many of the patients are on anticoagulants. Don't forget to look at the PT-INR. Look at the PT-INR, and if it is more than 1.4, 1.5, try to avoid it. We don't want to cause any injury or a hematoma by putting a needle. These are the few simple important things, technical things, and day-to-day things we forget, but we should not forget definitely before doing the EMG. Now, coming to the as I had presented the case, this is the EMG of the patient, and yes, the CPK was about 200, and this is the EMG. See it and try to tell me what is the diagnosis. This is spontaneous activity.
Yeah, Dr. Anusha, you can.
I'm not able to hear, sir.
You can see them, and try to. This is spontaneous activity, by the way.
Fifth, sir.
1 second. What did you say?
Fibrillation, sir.
Yeah. What is more evident? Just look at it and tell me. Right? This was the spontaneous activity. As soon as I placed, this is what I got. Right? One. Here, I do agree there are a lot of FIPS and positive sharp waves, but the large one were the fascics which were occurring.
Okay.
Yeah, anybody would like to comment about the MUP? What is the MUP you are seeing?
Yeah, doctor.
Yeah, anybody can take up and say, does describe the MUP as I told what you are seeing.
Polyphasic with multiple serrations.
Yeah, there so many phases are there. First and foremost, what we are seeing is that such a huge amplitude we have, along with multiple turns are there, multiple phases are there, long duration is there, all suggesting a chronic neurogenic process going on. This is in spite of his maximum activity, this is the recruitment we got, interference, definitely suggesting a reduced interference. Therefore, you see, the clinical picture was a myopathy. Though I agree, CPK was normal. Many times we will think that this is a burnt out disease, but until you put a needle, you won't know that this is a neuropathy going on. Therefore, these are the cases in which a needle EMG has a very important role, especially childhood weakness, acute radiculopathy, brachial plexus injury, apart from definitely MND. Therefore, clinical EMG is a skill all of us should acquire and keep on practicing so that we can make out what is occurring. This is the what I would like to end my thing. Many times, especially we think of something, we think of a MND, especially a bulbar onset MND, but we don't find, even in the tongue, don't write off that, no, this is not MND. You should give time. Ask the patient to come after 3 months so that you will again do and find out. Other cases that, especially in radiculopathies, we clinically think that this is a radiculopathy. We will check only one limb. Don't do that. Always sample a muscle from other limb and sample from upper limb also. I have made mistake. There was a person who came limping with a severe low backache. It was sure shot radiculopathy for me. But 2 months later, I found out that not only he had such neurogenic changes in his left leg, but it was also present in the right hand and the right lower limb, suggesting it was not a radiculopathy, but a MND. Most important, sampling of muscles and over a period, not confirmed, don't give your final suggestion. Ask the patient to come after some time and again check it. This should be these are the final points I would like to say. If anybody has some questions, we have some time, I think so, we can discuss. Okay, thank you. Thank you for a patiently hearing.
Thank you, Praveen sir, for nicely presenting this session. And if anybody have any questions, they can ask by unmuting themselves.
Yeah, sure.
CRD, somebody was there.
Yeah, what happens is that CRD, it's a type, there is a continuous activity. What happens, there is a wonderful diagram in a Shapiro. What happens is that here the impulse is rotating among the same muscle fibers and you can have continuous activity. I don't have it, but we had few images of few videos of doublets and triplets, which is some sort of a CRD. I will share it on the WhatsApp. Yeah, I had shared initially only. I will again show it. Right. Normally, what we say is that 5 millivolt you should take it as a normal, but right. Lowest is about 100, but average is about what we see is about 200 to 300 to 2 millivolt. Microvolt is very small. Normally microvolt we don't take it. This is a big average. About 100 to 200 millivolt is the thought to be normal. More than 4 millivolt, they are all considered to be very high. One question I would ask, I hope all of you have been exposed to EMG and doing it in the hospital on a regular basis. If not, it is a skill we should all acquire and keep on practicing later on also.
Sir, in myopathy and neuropathy, what is the MGC?
In myopathy, it's very low. In myopathies, you will hardly get it. It is about less than 100 microvolt. And what happens in acute neuropathy also, because there is a nerve damage, the MUP will be small. But if there is a chronic neuropathy due to re-innervation, you will get the large amplitude. Even in acute neuropathy, the amplitudes will be quite low. There is a fallacy that okay, neurogenic means always it's high, but neurogenic over a period of time. If it is acute one, you will already all get our low amplitudes. If no more questions, we will call it a night, and I'll share all the videos, and I also share the doublet and triplet video on the WhatsApp. And so Shailesh, I think so you can forward that to the Telegram.
Yeah, yes, sir. Yes.
Okay, then. Shall we
Yeah,
close
okay.
down?
Yeah. Thank you everyone for listening this presentation. Thank you, Praveen sir, for presenting.
Thank you.
The EMG. Thank you, everyone. We
Thank
can
you.
close it.
Sure.
Yeah.